Friends, healthcare can feel like a world unto itself. I think we all agree. And like many a foreign land, it tends to have its own language that's unique. Our expertise makes us want to be accurate and precise. But sometimes expertise can be so specific that it can get in the way of our being understood, especially when we put ourselves in the perspective of our patients and our members who are just trying to understand what instructions that we provide to them. I can read it, but I don't understand it. Whether it's trying to convert mLs to teaspoons or understand that edema means swelling, there's an assumption of understanding we all need to be mindful of taking for granted. Just because we know what we mean, we can't assume that others hearing us are going to understand what we might mean. So we might take it for granted that every patient we run into is going to just know that cardiac means heart or that benign means normal. Language can be a wonderful, magical tool. We just need to take care that it doesn't become some kind of a barrier or maze as we express ourselves. One story I always remember was from a pulmonologist who had prescribed an inhaler for a patient's allergies to their cat. And then the patient came back a week later saying he was no better at all. Nothing had improved. Because it turns out he was spraying the inhaler on the cat. The label on the bottle said, "Keep away from children," so I stayed away from children. We see the situation. Now let's learn a bit more about what we can all do to improve things, shall we? We have two presenters joining us here today. They'll be playing a little bit of tennis, going back and forth and co-presenting for part of our presentation. Dr. Cliff Coleman is a national, international expert in the field of health literacy. His award-winning work focuses on improving health literacy and clear communication training for health professionals, which is all of you. Cliff is an associate professor of family medicine at Oregon Health and Science University School of Medicine here in Portland, where he serves as clinical thread director for education and health communication, professionalism, and ethics. In 2021, Cliff became the inaugural Doris and Mark Storms Chair in Compassionate Communication for the OHSU Center for Ethics in Healthcare. His practice at OHSU's Richmond Clinic, a federally qualified health center in Portland. He receives his bachelor's in psychology from Dartmouth, a doctor of medicine from Stanford, and completed a dual residency in family medicine and public health and preventative medicine at OHSU, with a master's of public health from Portland State University in 2004. This morning, Cliff's going to be joined by Bhumi Khambholja, who manages a grant-funded project at Wisconsin Health Literacy, joining us from the state of Wisconsin this morning, a nonprofit organization based in Madison where she creates, plans, implements, and evaluates health and digital health literacy programs to reduce health disparities, something we're all very involved in. Prior to joining Wisconsin Health Literacy, she worked as a community pharmacist in an underserved area. So we have two really great presenters that are here to share their knowledge and wisdom with us this morning. To start things off, please join me in welcoming Dr. Cliff Coleman. Cliff, take it away, sir.
Awesome. All right. Thank you, Paul. Can you hear me okay? All right. Cool.
Great.
I am so excited to be here, and I'm just really honored to be invited and really pleased to get to join you here with my colleague Bhumi from Wisconsin. This is really special for me, and I don't think Paul knows this, but I actually got my start in the field of health literacy at Care Oregon. In 2003, I had just finished my family medicine residency, and I was starting a year-long residency in public health and preventive medicine, and I was doing my practicum, which happened to be at Care Oregon when your offices were on 4th Street. And I was working with David Labby and Dean Haxby and some of those folks. And at the time, we were, as we probably still are, thinking about ways that we could help healthcare professionals and clinics and hospitals provide better care for patients. And we were looking for initiatives in that area. And it occurred to me at the time, and some of the other folks that were there, that we really weren't paying attention to the sort of the patient side of the equation and trying to figure out how we could help patients use the system more effectively. So I'm not kidding. I literally one night dreamt that there should be something called health literacy during this year. You know, as a resident, you know, you're not getting enough sleep, and so those dreams get kind of weird and vivid. And I dreamt this idea. I woke up the next morning, I Googled health literacy, and lo and behold, there was something called health literacy, and there were some people talking about it. Not very many. There was not very much out there. And as a matter of fact, there were only 119 papers in the medical literature that involved this topic of health literacy at the time, 119. Today, there's tens of thousands of papers on this topic. There's no way any one person could be up on the entire field. But back then, I was able to read all 119 of those papers because I had this time protected with my work at Care Oregon. And over that summer, I became quite literally, I believe, the only person in Oregon who had heard of health literacy at the time. And from there, things just kind of snowballed through my career. So I really owe a great debt of gratitude to Care Oregon for helping launch what has been a very satisfying career thus far, and I hope is going to be continue to grow. So I'm so thankful for being back here with you now 20 years later to share with you some of what we've learned in these past 2 decades about health literacy. And then what I'm particularly excited about for is the question and answer period after, to maybe even do some brainstorming around some of the ways that Care Oregon can use its leverage to help move this field even further down the line. So let's, without further ado, I'm going to start with just talking about some fundamentals around health literacy. And I wish we were in a room together. I would ask you all to give a show of hands who feels like they really understand and know a lot about health literacy, and who's fairly newer to these concepts. Generally speaking, when I do that, I get a bit of a mix. There's usually a few people in a group of this size that will know some things about health literacy, but a whole bunch of people who have had really no exposure to at least the formal ideas in terms of their training. Haven't had any classwork or attended a conference or read specific papers around health literacy. So I think there's probably a range of experiences here today as well. So I'd like to just take the first period of time here to do some level setting, make sure we all kind of have a common starting point here. And what I'm going to try to do at first here is just kind of paint some broad brushstrokes around this field. This is a very broad field. It really touches on literally every aspect of health service delivery. So I'm going to kind of help us recognize some of that breadth, maybe go in to see some of the depth in a few places here, but really just trying to give us this flavor for the possibilities here. Then after that, we'll narrow things down and really try to focus a bit more on this idea around pharmaceuticals and prescription and adherence and et cetera. So I'll start with this quote from George Bernard Shaw, who said, "The greatest problem with communication is the illusion it has occurred." And this is really the story of health literacy. What we've learned over these last 2 decades is that what we think looks and feels and sounds like good communication with patients and caregivers generally is masking a deep-seated problems with misunderstanding, missing information, and disempowerment for getting clarification. So I'm going to use that theme as we move through this first portion today, this idea that this illusion of clear communication is happening. I'll start with some definitions here. I'm going to give you 2 different definitions of health literacy, one that relates to patients and one that relates to us as healthcare professionals. So for patients, we can define personal health literacy as a person's ability to find, understand, and use information and services to inform health-related decisions and actions. In other words, get access to information, be able to process that information and use it effectively to achieve one's health-related goals, right? And optimize health, wellness, and well-being. Now, on the other side of the equation is us. And so we could talk about organizational health literacy as the degree to which organizations, and by organizations I mean not only the organizations like CareOrgan, but all the people who work for our organizations, the degree to which we equitably enable individuals to find, understand, and use services and information. So, we as healthcare professionals have the specialized training, and we control the flow of information to patients and caregivers. And it's up to us to decide how we want that flow to occur. Currently, the current state of the world, at least here in the United States and actually everywhere else as well, is that that flow of information is made really unnecessarily complicated. And so certain groups within our communities are better able to cope with that type of information, and others are less able to. So people with higher education will, as we'll see in a moment here, tend to have higher health literacy and are better able to deal with this unnecessary complexity of health information that's flowing out from our systems and our organizations. And folks who've had lower education and less quality education are less able to deal with that flow of complex information. And so we currently have a situation where we're not achieving that equitable distribution of health information or equitable access to health information. And so there's a great opportunity here for us to work on equity issues by producing a system that provides clearer health information as our baseline or as our default. Now, here in the US, we have a really big problem with health literacy, and it's gone unrecognized for a very long time. I'm showing you some data here that is actually fairly old. If you see this reference here is from 2006. So this might seem to you like, oh, this is old and kind of stale and outdated. But I could show you other more recent data that's the same. I just have chosen this image because it's helpful for us to be able to kind of get our heads around some of the issues here. These data are no better today than they were in 2006. And in fact, things are probably worse. And I will show you some of that later on. But what we're looking at here are data from a survey called the National Assessment of Adult Literacy, which was a survey that the U.S. Department of Education did, where they went out and took a nationally representative sample of adults, English and Spanish speakers, and they went and they surveyed them in the comfort of their own homes, actually. They gave them a reading comprehension test, like many of us have taken many times before. It's a booklet of questions. You read a paragraph, and then you have to answer a multiple choice or a fill in the blanks type of question. And all of the paragraphs, all of the reading samples are somehow taken from health-related materials, which gives us this kind of proxy measure for health literacy. Some of the questions are pretty easy to answer. Some of them are very hard to answer, and there's a range in between there. And there's page after page of these questions. And so when you do this over a broad group of adults, you get a very clear picture of the average skill set of adults in the United States. And what we see here is this top bar, these colored boxes are representing percentages of the population. So we can see 14%, 22%, 53%, and 12%. And these correspond to skill levels, so which you can see down here below. So we've got 14% of the US adult population, which has really below basic health literacy skills, very low, able to answer some of the simplest questions on this reading comprehension test, but not any of the more complicated ones. An additional 22% have what we'll call basic skills, a little bit, able to answer a little bit more difficult types of questions, extract information a little bit better, but still not a high level. And we combine these two groups, that's where we get this 36%, 22 plus 14, 36% of adults with low health literacy. This group has health literacy skills at baseline, which are really inadequate to deal with the usual typical kinds of health information that everyone is going to encounter when they come into a healthcare setting. If they come to a clinic, they come to an emergency department, they get hospitalized and they're seeking services. This group's baseline skill set is going to be inadequate to fully benefit from the typical kind of way that we're going to speak with them, the language we're going to use with them, the written materials they're going to encounter, etc. Now, you can see like a big check section of the population, 53% had intermediate skills and 12% had what we call proficient skills. But these groups are all at risk as well. And the reason why is if you can imagine what it's like when you're seeking healthcare, when you're not feeling well, if you're feeling sick, let's say you're in pain, you've hurt yourself, or you're nervous, you're worried about what you're going to find out. You think there's something, you're going to find out something's wrong with you. Any of those conditions, our ability to think clearly, process information, retain information, and make decisions goes down in those times of stress. And so essentially, anytime a person is seeking health services, when they need to have their health literacy skills the most, those skills are likely to be lower than they would be at baseline. And so we're all at risk at all times. Now, literacy demands are really put on patients and caregivers kind of at every point of contact in our healthcare system. And we put a lot of demands that are based in literacy skills on people. So I just wanted to give you a sense of that, a little bit of that flavor for that. You can see here this kind of, I've got sort of 6 domains of literacy here. We've just been talking about reading and writing skills in that reading comprehension survey that I was just discussing there. And we could add to that this idea about numeracy, which is a person's ability to use basic numbers and mathematical concepts in general conversation. I'm going to talk a lot more about that in a little bit here. We could put these all together and think of them as kind of print literacy, a person's ability to deal with written information. And I can give you some examples of where we put those demands on people, right? We ask patients and clients and caregivers to fill out forms. We ask them to be able to understand and sign consent forms for either treatment or participation in research, et cetera. They have to be able to understand prescription labels. We're going to talk a lot about that and actually how difficult that is. Be able to determine dosages for over-the-counter medications. For example, there's a lot of literature on that. Follow written instructions, especially complex multi-step instructions. Be able to benefit from the health education materials that they might be provided, brochures and other materials that are designed to help educate patients. Be able to keep appointments, which often involves using written materials like calendars, et cetera. Be able to follow signage. So this is a navigation issue. If I have someone here at my hospital at OHSU and I ask them to go, get an X-ray, can they get to that place by following that written signage? And then more and more communicating with their team, with their healthcare team electronically. So there's a lot of written demands here. As a physician, the majority of what I do with people, though, is spoken communication, that oral literacy stuff. So these are listening and speaking skills. And there's a ton of demands put on patients, caregivers, and clients in that area. Some examples would be just calling to get an appointment, being able to navigate a phone tree, for example. When coming into a healthcare environment and being able to describe what's going on or what a person's concerns might be, having that vocabulary and that ability to describe. Likewise, being able to understand the vocabulary and concepts that they're hearing from their healthcare teams. Being able to understand and follow verbal instructions, keep those kind of in order in a person's head, and being able to confidently organize their thinking in a way that helps them formulate clarifying questions. We're going to talk more about some of these in a little bit. And then the last domain here is this idea around cultural and conceptual knowledge, which is really basically what does a person know? What have they learned throughout their life? And I'm talking about kind of book learning here. Well, it turns out that if we think about young children and they're learning to read in that age range around kindergarten up to 3rd grade, the general task there is to learn how to read, learn how to see letters and words in a written format and decode that and turn that into meaning, right? That's learning to read up to 3rd grade. After 3rd grade, we spend the whole rest of our lives reading to learn. And so that's for everything. That's, biology and history and English and social sciences and all the other things that we learn as we grow through our childhood and into adulthood. Person with lower literacy skills, if a kid makes it to the third grade not reading at the same level as their peers, studies show that they're never likely to catch up with their peers. The peers' skills are going to kind of accelerate away from them, and this third grader is going to grow up to be an adult who has lower average health literacy skills, and as we showed before, is kind of likely to be one of those sort of 36% of the adult population who has low baseline health literacy as well. And that has implications for the way they receive care as adults, right? So this conceptual knowledge, what does a person learn? If you're a lower skilled reader as a young person, you're likely to receive less formal education, so likely to stop going to school after, generally speaking, high school, finish high school and not go beyond. Less likely to read for pleasure, less likely to read informational materials. And so we'll have learned a different set of knowledge than your healthcare team might expect. And so that has implications. We saw this during the pandemic, where we had difficulty connecting with people who didn't understand germ theory, this idea that there's these things you can't see which can get into your body and replicate themselves, make you sick, then get out of your body and go into another person's body and make them sick. That whole theory relied on some baseline learning that a lot of our adult population lacked. We can talk about pharmacokinetics, or the way medicines work in our bodies, and this idea that that I take a pill and it has to get distributed throughout my body in order to do whatever it is that it's supposed to do, but then my body metabolizes that and it disappears and it needs to get replaced within a certain time frame. Those concepts are all based on literacy skills and prior learning, which a lot of our adult population don't have. So you can start to see how this can make things more challenging for us as we try to deliver health services. Now, part of this problem, or this issue, I should say, is that the United States is really considered a fairly highly literate society. Probably around 98% of people in the United States can read. And so the question is just because you can read doesn't mean you can necessarily extract useful information from what you've read. Right. So let me show you an interesting example of that. This is a study, and this goes back to 2006 also. In this study, this group of researchers, this was in Louisiana, they took a group of volunteer adults and they gave them a reading skills test, kind of like the one I was telling you about earlier, which helped them estimate where these people's grade level reading skills were at. If you were reading at a 6th grade reading level or below, they kept you in the study. So these are people with pretty low reading skills, 6th grade or below. And then one-on-one in a private room, a researcher sat down with each of these volunteers and handed them a real prescription pill bottle that had a real label on it and asked them if they wouldn't mind to try to read the label out loud. So in this case, 71% of these adults were able to read the instructions verbatim, which said, take 2 tablets by mouth twice daily. Then this researcher said, great, now if you wouldn't mind showing me or telling me, how would a person take this medicine on a daily basis? How would you take this? But only 35% could actually demonstrate or describe how to take it in the way that it was intended, right? 2 tablets, essentially 12 hours apart, dividing the day into halves. So the reading piece was there for many of them, but the ability to extract useful information from that was missing. I'll show some more examples of that in a minute here. One other example of the many that we could share today, in the more recent study, this is a study that was done a couple years ago, 2 years ago, I think. These researchers interviewed people who were attending a state fair. So people were feeling well, they're out in the community, and they stopped by a booth and took a survey. 215 adults surveyed, 65% of them had a college education. In this sample, 25% of these adults misinterpreted this phrase, you are to take nothing by mouth after 4 p.m. All right, so we've seen examples, take 2 tablets by mouth twice daily. We've seen this one, you're to have nothing by mouth after 4 p.m. These are very standard prescription instructions. These types of instructions are given numerous times every single day at my clinic and everywhere else in the world. But a large chunk of people have a hard time with them. And that part has been unrecognized by a lot of the people who are either producing these prescription instructions or are helping facilitate people to get these prescriptions. I'll give more examples in a little bit here. Sorry, there we go. Okay, so I've got a blank screen here. I have a little thing that says trigger warning here. There's some sexual trauma content. I'm going to show some words here. Some of them relate to some sexual trauma, so I wanted you to be aware that that was coming. I'm just going to show a list of words. What this is actually a research tool called the Rapid Estimate of Adult Literacy in Medicine. It's just a word list, has 66 words. We'd have these on a laminated card, and we'd ask a research participant to read them out loud for us. And it turns out if a person can pronounce a word correctly, they tend to have an adequate working knowledge of that word. And if they mispronounce a word, that correlates pretty closely with a really inadequate working knowledge of what that word is all about. And so if we can give the people this reading pronunciation test, which takes just a couple of minutes, and it's very helpful for us to estimate a person's health literacy skills in that moment. So I was just going to put up this list for you here and just give you 30 seconds or 45 seconds or so to just read to yourself, starting with the left-hand column, reading down, and then the middle column and then the right one, and then I'll come back and we'll talk about this. So just go ahead and read that for yourself. All right, and I'll stop it there. If you didn't get through it all, that's totally fine. What I just want to point out about this is, these are all kind of health-related terms. They start with simpler terms on the left, single syllable, and they become a little more complicated as they move through. But I would argue that none of these are really extraordinarily weird healthcare terms. This is not like the super jargon terminology. It is to some degree, but I would argue that this is the very type of language that any patient would probably expect to hear if they come into a healthcare service environment, like a clinic or emergency department or in the hospital. It might not be these exact words, but it would be these types of words, okay? And so that's important, because let's think about how we would score this thing. So I told you if you pronounce it correctly, you get a point. If a person can pronounce somewhere between 0 to 18 of these, that correlates with reading at a less than a third grade reading level. If they can pronounce 19 to 44 of them correctly, that correlates with a 4th to 6th grade reading level. 45 to 60 words pronounced correctly is a 7th to 8th grade reading level, and 66 or above is something like above a 9th grade reading level. Okay, now this is interesting because here in the US, our average adult is reading at an 8th grade reading level, average, right? So half of US adults are reading at a level below an 8th grade level, and half are reading at a level above 8th grade level. And this is our average. But if you think about this might mean that our average patient or caregiver would look at a list like this and mispronounce or be unfamiliar or not have a full working knowledge of somewhere between, say, like 6 and maybe 20 words on a list like this. And remember, these aren't necessarily the words that they're going to be exposed to, but it's this kind of language. And now we put that average patient into a healthcare environment, and we have to really recognize that if they come to my clinic, they might they're almost certainly being exposed to words that they don't have full grasp of the meaning of. And what does that do to your ability to use that information you're receiving? What does that do to your confidence in that information and your willingness to act on it without feeling certain that you understood it? This has big implications for adherence to treatment plans and a whole bunch of other outcomes that we are all interested in. So let's take a quick listen here. This is about a 3.5-minute clip, an excerpt from a longer video that the American Medical Association put out some years ago. But I just want to have us listen to how some patients describe their experiences with health-related information and literacy-based demands. So there's obviously a lot that we could unpack in this short segment here, I want to key in on a couple of things that we heard about the way patients interpret their lack of understanding. We heard one woman early on saying, her words were, "You're in this room with this intelligent woman or man who assumes you're just as intelligent as they are," and that is not the case. So she's using this word intelligence, linking that with being able to understand her health care, right? Then we have this woman here whose her words were she didn't want to reveal her sense of stupidity, as she said. And so she hid the fact that she was surprised. And what we see, and we've seen this in other studies too, and we see this when we do focus groups with patients, is that that patients equate not understanding their healthcare with having something wrong with them, with not being smart, with not being intelligent. And we can intellectually recognize that, no, this is just a difference in education. This is a difference in exposure, right? Healthcare professionals have had training to understand these things. And since if you haven't had that same training, there's no reason why we'd expect you to understand it. But that's not how patients see it. And so what happens here, though, is we've set up this dynamic where patients feel a great sense of shame when they don't understand something. And anytime any of us feel shame, right, we're going to try to protect ourselves. So what patients are doing is they're hiding the fact that they don't understand, right? They're trying to get by. They're trying to act like they understand and then hope that they can figure it out later, right? The woman is like, "I hope I don't make a mistake with my medicine because I didn't understand anything they said." That's part of this illusion that communication has occurred, right? They're giving this they're presenting to us a smile and a nod and a thank you, and then leaving with great amounts of uncertainty. Now, what we know that lower health literacy is linked with all kinds of adverse outcomes that we're concerned about. We know that people with lower health literacy are less likely to use preventive services, like get vaccinated, like get cancer screenings, like go to wellness checks. We know that they're much less likely to be able to understand how their medications should be used and what they're for, and they're much less likely to take them as directed. We know they're more likely to have difficulty navigating the healthcare system. We know they're more likely to use emergency services. In fact, we heard the man in the video, he said he even got to the clinic. He had an earache, got to his clinic, but then he got intimidated by the paperwork that he was asked to fill out. And so he left and his condition worsened, and then it became more of an emergency issue. Patients with lower health literacy are more likely to wait too long. And so when they do present to care, they're more likely to need to be hospitalized because whatever their condition is has progressed far enough. So we see higher rates of hospitalization for conditions. We also see, once a person has left the hospital, we see higher rates of readmission within 30 days for patients who have lower health literacy. So we know this is a concern for Care Oregon and other agencies. We know that people with lower health literacy are more likely to die from their conditions. And this is true certainly for heart disease, but also true for just all-cause mortality. And then really importantly, more recent work has shown that health literacy is a better predictor of racial and ethnic inequities and disparities than our more traditional measures of socioeconomic status, which are generally years of education and income. And this makes sense that health literacy skills would be a better predictor than years of education, because you could go to, finish high school, 12 years of education, but if that school was a lower performing school with lower quality teachers because of, poor tax funding, for example, you might end up being like an average U.S. adult, not reading at a 12th grade level, but reading at an 8th grade level. So we can see that health literacy skills predict are better predictors in that sense. Now, I wanted just to mention real quickly about this idea about navigation, because this is one that I think Care Oregon clients deal with quite a bit. Navigating the healthcare system is a health literacy issue, and this very busy slide here is just designed to represent the complexity of what has to happen between the time a person decides they need help for some medical condition and the time they actually get the help. So we could think about the man with the earache. He realized he needed some help. he needed to figure out where he could get that help. So he got an appointment. He had to get an appointment at a clinic. He had to get to that clinic. He had to get there on time so his appointment wouldn't get canceled. Once he got there, they asked him to fill out paperwork, and that's where he fell through the cracks. But if he had made it past that step, he would have gotten back into the appointment. He would have to answer some questions, understand some information. Then he would likely have received something like a prescription, which he would need to take somewhere else to a different facility to get a medication. He might have to deal with some co-payments around that. He has to get the medicine. He has to interpret the prescription label, take it correctly, and all the while he doesn't feel good, right? All these different places where he could fall through the cracks. So what do we do with this? This is all pretty demoralizing, right? But we have really good solutions to it. They just haven't been implemented on a really system level to a great extent yet. But I'm going to talk to you this idea about universal precautions. So first, I'll kind of give you this. I'll just rehash some of what I've said to give you the sort of why, and then I'll tell you a little bit more what it looks like. So we know now that health literacy is really common, right? Or low health literacy is really common. We know that people hide the fact that they don't understand it. So we can't really tell what a person is understanding. And as a matter of fact, when we've done studies that looked at healthcare professionals, they can't tell. They can't tell which patients are understanding them, and they can't tell what information those patients are understanding and what they're not understanding because of this illusion that's being created. We have some screening tools. I showed you one of them, but we know for a variety of reasons, which I won't get into today, they're not appropriate to be used in a clinical environment. They're only useful for research settings, and so we don't have that as a tool. What we do have, though, is this idea about universal precautions, which means treating everybody the same, using the same approach with every patient every time. And what this for us means is assuming that everyone is at risk for misunderstanding, missing information, or confusion. The universal precautions approach says, don't try to adjust the complexity of your communication to what you think you know about this person in front of you or your audience. So if you have a PhD researcher that you're trying to communicate with, don't try to communicate with more complexity for them than you would for someone who didn't finish high school. You're just going to be wrong. We're going to get it wrong. We're going to provide inequitable information across the board. What we want to do is provide the clearest, easiest to understand, simplest message for everybody, every time, at every point of contact. And I'll show you a little bit of what that will look like. Inevitably, with someone might ask, well, won't my highly educated, high health literacy patients be offended if I, provide information that's too simple, too basic, too easy to understand, right? And the studies have looked at this. The studies that have been done that showed a broad range of educational experiences and health literacy skills showed that everybody wants the simplest messaging, the clearest communication, the plainest language. So no. The other thing that's important to recognize is some people get concerned that, how patients will take it if I quote unquote dumb it down for them. And I really push back on that idea of dumbing down. Dumbing down to me is like talking with an adult as if they were a child, which I don't think anybody's likely to do. But what we're really asking people to do is to take very complicated health information that took specialized training to understand and distill it down into a message that's easily understood by a person who hasn't had that training. And this is an extremely complex communication task. It's difficult. This is not dumbing it down. This is harder than anything. So I really would suggest that dumbing down is not a concern. So let's talk a little bit about best practices, and I'll share just a few of them with you here. So we have this is the situation we've got set up. We've got this dynamic happening here where the left-hand side of this diagram is representing patients or caregivers and their individual skills or abilities, which we can call their health literacy or their personal health literacy. And as you remember, like that can kind of go up and down from day to day, depending on how the person's feeling and what's distracting them and how they're, if they've had enough sleep and if they're in pain or whatnot. Person's health literacy skills can go up and down. On the right-hand side of this diagram, we have this bigger red arrow, which is there to represent the complexity or the demands that we as the healthcare system are constantly putting on people And as you can see, this red arrow is much bigger than the yellow one. Basically, every time a person interfaces with a healthcare environment, the information or the demands that are being put on them really outpace their skills in that moment. And so our job is to be constantly thinking about this, our piece in this equation, us being that red arrow, and thinking about how do we shrink that arrow? How do we lower barriers to understanding? How do we make things as easy to understand and easy to act on as possible? And I call this clear communication. We could call this organizational health literacy, as I showed you in that earlier definition as well. So some best practices comes out of some work that I was involved in with some consensus work studies that we did, some national consensus work studies we did. We went out and we reviewed the entire literature on what are the clear communication best practices that people are talking about out there. Did a very large literature review and then gathered a group of health professions educators from across all the professions and had them decide on which of these best practices were appropriate for all healthcare professionals. So I'm talking, providers and nurses and pharmacists and dentists and allied health folks and everyone. So they gave us this list, and we had 32 clear communication best practices on it, which was a lot. It's too much to really take to a dean of a school of medicine or a pharmacy program and say, now you need to start teaching all these 32 things. So the second study we did was we took a national group of health literacy experts and we asked them, here's this list of 32 best practices. If you ran, health professions education, if you were in charge and you only had the resources to teach one thing about clear communication, what would that one thing be? And if you had the resources to teach two things, what would the second thing be? And the third thing and the fourth, and down the list of 32. So I'm just going to show you like the top four. There's 32 of these things, but we'll just look at top four. I mean, I'll linger on a couple of these and I'll move through the others pretty quickly to get us moving on with the program. So we'll start with this one about using plain language and avoiding unnecessary or undefined jargon. So medical jargon, right, is the specialized language that we've learned either through our formal training or our education that was needed to do the work that we do, or we've learned it on the job through work experience. And this is the language we use to communicate with each other for precision, as Paul mentioned at the beginning of the program. Helpful for us to communicate with each other, harmful when it spills over into our conversations with patients and caregivers. Sometimes, I now really emphasize sometimes, jargon can be necessary, meaning that it can be helpful to the person for them to learn it. The thought that's coming to my mind right now is a term called hemoglobin A1C, which, if you're familiar with this, is a blood test that people who have diabetes receive. It's a terrible jargon term, but it's an important one because it's what a lot of treatment decisions get based off of. And patients really who have diabetes are just going to need to learn that jargon term, and it's a quote unquote necessary term in my mind. But I would say 90% or more of the jargon that we hear in practice, when you go out and you listen to people talking with patients and caregivers, 90% or more is really unnecessary and actually unhelpful and probably harmful. Again, undermining a person's confidence in their ability to understand, which I think plays out into non-adherence and other problems. Jargon's a pretty interesting, to me, field. I won't get into it too much, just to show you that there's sort of three main flavors of jargon. We can talk about technical jargon, which is words that really have their meaning or only have meaning within a healthcare context. So terms like glucometer is really, you wouldn't see that anywhere besides some talking about some kind of healthcare related issues. Cath lab, even these acronyms, COPD, PRN, examples of those. Then there's quantitative jargon, which is not medical words, but words like unlikely, increased, high, excessive, words that require some clinical experience to sort of know what they're referring to. And then lastly, lay jargon, which are terms that have one meaning inside a healthcare environment and a different meaning outside of a healthcare environment and can be confusing in that sense. So some examples in the hospital, you'll hear people telling patients your vital signs are stable, right? Which is good. It's good. It tells you this person's not getting sicker. Things aren't getting worse. But stable to some people also means the place where you keep the animals. It also means that you're not going to tip over. So there's other meanings there. The terms positive and negative are really classic ones, right? If you're getting a medical test, let's see if I'm giving you a test for some condition. Generally, a negative test is good, right? That's usually good news. Outside of healthcare, however, negative is negative, right? It's bad. And likewise, positive inside healthcare is usually bad. It's usually good outside healthcare. All right. We could talk more about that later. Let's listen to what a really quick 1-minute clip here of some people on the streets of New York City talking about what the word hypertension means to them. So for those of you in the pharmacy world, I'm not sure if Haldol works for hypertension. I guess under certain circumstances it might. But what you can see here is hypertension, a term that is widely thrown around in healthcare environments, is unfamiliar to a lot of people. Even people who have the condition, it can be unfamiliar to, right? So we might want to say high blood pressure instead. Here's some pictures of some whiteboards. These are dry erase boards that you'd see in a hospital room. These are from my hospital at OHSU. So if you're a patient laying in the bed, you'd look up on the wall and there'd be this dry erase board across from you, and it would have some information for you. So it says things like my plan, information that's supposed to help engage patients and tell them what's going on. And I just would point out that that our use of precise language that we use with each other spills over into these interactions with patients. And here's some examples. This first person's here that says the reason for their visit is hypoglycemia, right? But nobody who's ever had hypoglycemia has ever used that word, probably. At least that wouldn't be the most common way to say it. They would say maybe I had low blood sugar. So we could use that kind of language as well and help reduce confusion. This next person's active issues include syncope, which I would venture to say most people who've had that problem wouldn't call it that. They might call it, having passed out. This other person over here's plan for the day is DTV 6 to 8P, and their activity level is 2PA C with a line over at Walker. I don't know what DTV 6 to 8P means. I do know that 2PA C line over at Walker means to help from 2 other people and a walker. And on and on and on. This person's plan for the day is incontinence care at ALF. I think ALF means assisted living facility. And this person's here for their diagnosis is FX humerus R circle side. FX shorthand for fracture. Humerus is the big bone in the arm. R with a circle around it means the right side. Could we just say broken arm? I think so, as we go through those. So another example, these are prescription, this is a screenshot of a prescription refill that I received for a patient of mine. And the instructions said to take 1 tablet by mouth twice a day to prevent thromboembolism. So I, of course, asked my patient, what does thromboembolism mean? And he didn't know. And I thought, well, that's really worrisome, because if you don't know what the medicine's for, isn't that going to be one of the easier medicines to just decide not to take? So I told him what it was for. I changed the prescription to say to prevent stroke, and he was appreciative of that. The other prescription on here was for duloxetine, in which the instructions said to take 1 capsule by mouth once daily via feeding tube. You can probably see a problem there. Take by mouth via feeding tube. That didn't work. But it also said for chronic musculoskeletal pain. However, this is not how you spell musculoskeletal either. This says musculoskeletal. And what's musculoskeletal pain? My patient was like, I don't know what that's for. And I said, well, you take that for your back pain. Let's put that on the label instead. He said, okay, that sounds pretty good. Thank you. Bhumi's going to talk more about this, so I'm going to move through these fairly quickly, but we can talk about some evidence-based prescription labels and some of the elements that are missing from our standard labels in my hospital system and in most, I would say. So, you could write, we've seen this example already today, 2 tablets by mouth twice daily. Patients could take that in any number of ways. We hear people say, I took 2 tablets at 8 a.m. and then I took 2 more at 10 a.m. to make sure I never forget taking my medicine, and I never forget, right? Well, 2 at 8 a.m. and 2 at 10 a.m. is not really going to achieve the benefits that we would expect from that medication, and it might actually cause adverse side effects. So we don't want to use that one. Of course, we could use the Latin 2 tabs POBID, and if we know that that opens things up to interpretation and is not going to necessarily be that helpful. But what we really want to recommend and emphasize here is a couple of things. Putting some time parameters on this, and Bhumi's going to talk to you about this, but adding explicit time parameters like every morning and every evening has been shown to improve correct dosing. Putting the reason for the medication on the label itself has been shown to improve understanding. And using plain language to describe that reason, right? Instead of saying for hypertension, saying for high blood pressure has also been shown to improve understanding. So we'll come back to this again. Let's talk about information overload quickly here. Information overload is the situation when information is coming in too fast or too much to deal with, given that whatever the situation is. When you're listening to me talk right now, I'm giving a lot of information overload here. Essentially, the slide that you're paying attention to and the sound of my voice that you're listening to right now, to focus on those two things, you've had to literally forget what just happened a couple of slides ago. You've had to set that aside and put your working memory in effect for what you're hearing right now. So information overload is a big problem for patients, however, because studies show us that the more information we give, the less likely people are to remember any of it. So specifically, studies showing that if we give 3 or more pieces of information, we can very easily watch how recall of any of that information plummets. Here's part of the problem. Multiple studies now show us that on average, in any given medical encounter, patients are going to remember on average 50% of what was talked about. So if you're seeing me in my clinic and we have a 20-minute office visit, and as soon as that visit ends, the patient steps out into the hallway and a researcher is sitting there with a clipboard and says, "Quick, tell me everything that you remember." On average, my patient's going to remember 50% of what we talked about. Couple problems with this. First off, we don't know, we can't predict which 50% they're going to remember. Are they going to remember the most important 50% or what we think was less important? It really depends on what that person's mindset was that day. What are they listening for? What are they worried about and are concerned about, right? If they're worried about cancer and I tell them, hey, you're of a good age to start doing some colon cancer screening, they're going to key in on that and not maybe some of the other stuff that I was talking about. The second piece of this is, of the 50% of information that they do remember, half of that they remember incorrectly. So now we have a situation where on an average office visit, a patient might leave really only retaining 25% of the information, at least correctly in their mind. And then you imagine what happens in a person's busy day and they go to work or they have to go deal with their family or whatever. They get home that night and they probably can't remember any of it. So information overload impacts that, and we want to try to limit the amount of ideas that we're trying to share to the ones that are the most need to know for that particular moment in time. Now, I'll just kind of gloss through these last two really quickly. Encouraging questions. This is something we teach our medical students and our residents quite a bit. Most of us will learn to end an encounter by saying, do you have any questions, right? That kind of professionalism thing, making sure a person has an opportunity to ask questions. Do you have any questions is a closed-ended phrase, and it really can only generate a yes or a no answer. But what we now know, right, is that people are very confused, but they really, really don't want to show that. And so almost always any patient is going to say, no, I don't have any questions. Thank you for your time. Even when they are confused and do potentially have questions. So what we can do is we can flip this and we can say, let's use an open-ended phrase, which requires the person to say something besides just yes or no, right? So we can say, what questions do you have? As one simple way to deal with this. Similarly, we can check for understanding by using a teach back technique. Teach back is instead of instead of saying, trying to check for understanding by saying something like, do you understand? Does that make sense? Do we have a good plan? Which again, for the same reasons before, people say, yes, we have a good plan. Yes, that makes sense. Yes, I understand, even when they don't, right? To protect their egos. A teach back is a technique that asks them to tell back what that plan would be, right? So some examples. I want to make sure I've explained things clearly. In your own words, can you please tell me back the plan? Or this is a lot of information. How would you explain this to your partner when you get home? Let me just show you some evidence around this. We've seen that the teach back technique has been shown to improve knowledge, improve adherence to medications, improve self-management for chronic conditions like heart failure, better blood sugar control for people who have diabetes, better adherence in rheumatology patient population. So there's some evidence that's emerging, and nicely, it doesn't add to the length of a visit. So we can really encourage that all healthcare professionals start using this as a way to kind of close the loop on understanding. I'll show you one quick example of how we do this. This is me talking with an actor who's playing the role of a patient.
Yeah. To make sure I've done my job well and explain things clearly, if you will tell me back the plan, I'm going to type it on your visit summary here, and then I'll send that home with you.
Okay.
All right?
Okay.
Okay. So, for your blood pressure, what are we going to do?
You're going to do some tests to check out my heart.
That's right. Yep. So test today. Okay. All right. And then what?
You're going to call me with the test results.
Yep. That's right. Call you. Okay. Yeah. And then what?
And then, you want me to come back in a week, I think?
Yeah, a week or two.
A week or two, okay. Yeah. And so do I need to make an appointment for that?
Yes. Right. So you need to make that appointment before you leave today.
Okay.
Okay. And 1 to 2 weeks is fine.
Okay.
Okay.
Mm-hmm.
Doing for time. We're doing okay. We're going to take a break here in just a few minutes. I want to talk about this idea about numeracy, then we'll take a quick break. So numeracy, as I mentioned way at the beginning here, is this idea of using basic math or numbers in conversation. We could define it as the knowledge and skills needed to understand and act on numerical information and concepts encountered in routine spoken and written communications. Math and mathematical concepts and numbers come up in virtually every single healthcare conversation, and certainly are a big part of every prescription medication conversation. Numeracy skills in the United States are quite low. These are data that are kind of similar to those national health literacy data that I showed you earlier. These are more recent from an international study that included the United States. And here in the US, these are from 2017. Measures of literacy. This is not health literacy, but general literacy. You can see that 52% of the population is scoring in the lower two categories there. But on numeracy, it's 62% of the adults scoring in the lowest two skill sets on numeracy, the ability to use basic numbers and mathematical concepts. And I'll show you some examples of those here. So on the left-hand column, we'll just say kind of what the category is, but I'm going to just read through the examples in the right-hand column here. So some examples of numeracy demands that we would put on people. No more than 3 grams acetaminophen in 24 hours. Call clinic if weight increases 5 pounds or more in 1 week. This would be for someone with heart failure. Reduce your daily oxycodone dose by 2 tablets every 7 days as part of a tapering plan. Reduce daily caloric intake by 500 calories as part of a weight loss plan. Take 1 tablet 3 times daily. We're going to hear more about that from Bhumi, I think. Add 2 units regular insulin for every 50 units blood sugar over 150. This is a very complicated numeracy task. Aim for a 10% weight loss over the next 6 months. Limit sodium to 2 G daily, G being short for grams. Unfortunately, we see this all the time, and then you go to the store and you look at food labels, and of course, their sodium is listed in milligrams, mg. So there's also a disconnect. Lab results, rating of pain, risk calculations, etc. So lots and lots and lots of numeracy demands put on patients. I will stop us there, and we'll take a 5-minute break. And when we come back, Bhumi Khambholja will talk to us about some more specifics around the prescription issues for the day.